Hey everyone, welcome to the Brain Body Reset Podcast. I'm your host, Spencer Zimmerman. Beyond the diagnosis and symptoms, there's a path to feeling better. Dive into the world of brain-body connection and learn how to optimize your health. This week I'm joined by my guest expert, Dr. Lorraine Maita, MD. She is a triple board certified and award-winning physician, writer, author, and speaker. She's known as the hormone harmonizer and detoxifier. Join us this week as we discuss the impact on hormone therapy and its role in mood and brain health. Enjoy. Lorraine Maita, MD, welcome to the show.
Thank you so much for having me. It's such an important topic. I mean, where would we be without our brains?
Exactly. Most important part of the body, but yet most people kind of go through life just hoping it's okay up there. And if it's not, they just don't know what to even do.
Exactly. That's why we have to treat the whole body, not just, your heart or your lungs or your skin or your gut. It's the whole body. You need, and the brain is sort of your central station there.
Yep, absolutely. And so people come to me and we do a lot of neurological rehab, but that's one side, right? You can improve the brain by going directly to the brain, but there's other things in the body that impact the health of the brain. And that's what we're going to talk about now is hormones. So very first thing, everyone thinks about hormones, right? Like, oh, for a guy, testosterone's about libido and getting jacked, right? Whereas females, they're just, you just have hormones so you can have babies, and that's kind of it. So obviously that's not true, else we wouldn't be having this conversation. So what can you tell us about these hormones and how do they impact the brain?
Well, the hormones, like the sex hormones, are not just about sex. I mean, we know that they build bones, they enhance muscle strength, they can lower lipids, and they can do a lot of other things. But hormones are actually made in the brain. Estrogen, progesterone, testosterone, DHEA are made in the brain from cholesterol. And they are potent neurosteroids and neuromodulators. So they act on the brain cells, and they all act in somewhat different ways, but they act synergistically to keep your brain healthy and to keep you functioning well.
Yep, absolutely. I know whenever I've looked at some of the research studies, they actually see kind of the volume of the brain even shifts during a female's menstrual cycle, depending on what's happening with her estrogen and progesterone levels. Which is kind of one of the things I'm like, oh, when someone's like doing, I'm doing the pill and I'm like, I don't know, like, are there long-term issues that we're going to see with the brain? Because it's, if the brain's meant to oscillate, I don't know how much I like messing with that. Now, I want to kind of break these down a little bit more into each one, right? So let's start with estrogen. And I think as we talk about this, it's really important to note that as we go through these hormones, guys, you're not exempt because we talk about estrogens, and females, you're not exempt when we talk about testosterone. All hormones matter for everyone. And if it didn't matter, you just wouldn't have any.
It always surprises women when I ask what is the most abundant hormones that females have in their bodies. It's testosterone. And they're all shocked because all of our estrogen is made from testosterone. And men, you have estrogen, but the men with the big boobs and the big belly, they're turning their testosterone into estrogen. And, that comes from inflammation, being overweight, drinking alcohol, not having enough vitamin D, not having enough zinc. So the hormones convert into each other because it all starts with cholesterol. It goes to pregnenolone, then it goes to progesterone, and progesterone can branch off to DHEA, which could go to testosterone, and testosterone, which can go to estrogen. So they're all interconvertible, and men have the enzymes to keep testosterone as testosterone. Women turn their testosterone into estrogen, and all of them are necessary for overall health, not just neuromodulation, but the hormones affect your mood, your cognitive function, meaning your ability to think quick on your feet, and your memory. So what I see happening, just think hormone surges. Think of a teenager. Their brains are not ready for the hormones, and the hormones are like ramping up and surging. So you have the boys that are aggressive and the women that are irritable and snappy, the young teenage women and the teenage boys. Their hormones are causing different effects. So it could cause, when a young man is not used to testosterone surging, it can cause rage and anger and irritability. And women's hormones, when they fluctuate, which, when you're starting to ramp up your cycle, they get anxious and irritable. And 1 minute they're nicey nice, and the next minute they're biting your head off, right? But estrogen starts to decline, and it fluctuates a lot in perimenopause. So I call them the 4 Ps: postpartum, perimenopause, the 3 Ps, and postmenopause. So estrogen is fluctuating a lot. Like after postpartum, it will go down and then it will start to ramp up. In perimenopause, it's all over the place. And in menopause, you're starting to sink. So this is when women are like, what's your name? That thingamajig, that little thingy. They can't find the words, right? So they can't find the words, and they feel slower. They're not quick on their feet. They can't remember certain things, and memory becomes poor. Their quickness is gone, and they're moody. They're tired, they're irritable, and they have a very significant increase in anxiety and depression. And a lot of it is hormonal.
Yeah, I mean, that's so true. And unfortunately, whenever they get some of that depression and anxiety, if they go the regular route, it's like, oh, well, here's your Prozac, or here's your some Balta, your escitalopram, whatever, versus being like, you know what? Why don't we just kind of give you some hormone replacement therapy, and then it takes care of it for a lot of these individuals, which we'll kind of go a bit more into that as we progress through this. But first, are there some distinguishing symptoms someone may have if we compare like estrogen dysfunction, imbalance, compared to like progesterone?
Estrogen, I call it the hormone of energy and growth. And when your estrogen and progesterone is peace and calm. So estrogen is like the gas pedal, progesterone is like the brake. To drive a car, you need both. You need to be able to modulate between. And this is why you can have, stable moods when they're in balance. And in perimenopause, we run out of eggs, right? And the eggs that are left are getting tired and old, and they may not make sufficient progesterone to balance the estrogen. So what women start to feel in perimenopause, and then it also goes into menopause, because you can even have low estrogen and not have enough progesterone to balance that. And you get that excess energy can feel like anxiety, irritability, impatience, insomnia. That's the energy part. The growth could be growth of the breasts, cysts of the breast, tender breasts, growth of the uterine lining, which can cause bleeding and spotting. You can have growth of fibroids, growth of ovarian cysts. You can have weight gain in the female places, breasts, hips, and thighs. So it's that hourglass Marilyn Monroe type of appearance. So, and then in menopause, you still have the anxiety and the irritability, and you can have depression in both. And you start to get achy. The words don't you can't find the words. This is really what happens. The memory starts really going, and the energy starts going. And women tell me they feel like somebody pulled a plug on them. Like they went from feeling lively and alive to like blah. It went from technicolor to gray, and they lose their libido. And that a lot of the symptoms in menopause occur in perimenopause. The difference is the definition of menopause is a whole year without a period. In perimenopause, your periods can be heavy or light, coming sooner or coming later, or skipping periods. They're irregular, and the mood swings go along with that. And, one of my hypothesis is in midlife, women get anxious and irritable and they're in your face. Men's testosterone starts to go down and they get more withdrawn. So you have one person going at you and the other one pulling back. And, my theory is that's midlife crisis. And I used to have couples come to me and I would, describe the symptoms and they'd both be nodding their head, and describe this issue and they'd both be nodding their head. It's a theory. I mean, there's no scientific evidence of that, but it's after 40 years of observing people and seeing what they go through. I do think that hormones play a huge role in how you see life and how you feel about yourself and how you feel about others.
Yep. Yeah. I mean, that's true. I mean, we know, especially on like testosterone, there's been research on that side. But the hormones do play a big role. And I want to go back to something you talked about, right? It really is more of the symphony of the hormones, because sometimes people are like, well, which hormone is it going to help me sleep better? Or which one's going to help with my anxiety? It's like,
yeah.
Well, some people, they notice more benefits with a progesterone because they take it at night, but then others, it's not about which one, it's about the right combination. And I think the which one comes from the medical marketing, right? It's like, here's your pill for this. And it's like, well, that takes care of it all. When it's like, it's really not that simple, because even within estrogen, we know there's different estrogens that, depending on where you're at in your cycle, pregnant or not pregnant, and even as you age, you get shifting of that balance. So that's really important to note. Now, one of the things that I am kind of curious on, is the whole definition of menopause. It seems that eventually that definition's got to change. I mean, the amount of people with IUDs and other things where they're like, honestly, I can't even tell you, right? And so unless you check their labs, which a lot of the times it never gets checked, they have no clue. Like, maybe they went into menopause 3 years ago, or maybe, and it's like, what, I guess, do we know yet how IUDs are impacting stuff? Because we have at least a little bit of an understanding of what the birth control pills are doing from taking it exogenously. But on the IUDs, do we really know a lot yet about what that's doing? And let's relate it to brain health. If you're finding this information valuable, please share this podcast with others and give us a 5-star review, as that is the only way this podcast grows. Please continue listening and keep enjoying.
Well, they act differently on the brain. And, for example, like, not necessarily with IUDs, but some progestins have androgenic effects. And think of testosterone, you get testy. So people get snappy and irritable. And I had one woman who's on 2 antidepressants, but she's on, I think, too much. She came from somebody else. Too much progesterone plus a progestin, which is synthetic, that is very known to cause depression. So too much progesterone can cause depression. It's a break. When you have too much, you're groggy, you're foggy, you're depressed. It's a break. You can't get going. You can't get motivated. And she was on one of the synthetic progestins that is very well known to cause depression. So she's on too much of the hormones, both of which too much can cause depression. And one, even if it's not too much, can cause depression. And then she's on 2 antidepressants to counter that, right? And that nobody measures. And if they do, they measure the wrong way. And now, no one, a lot of women have been deprived of hormones because of fear. And they shouldn't fear hormones. They now know that estrogen does not cause breast cancer. That's the biggest fear, right? Oh my God, it's going to cause breast cancer. I give anybody who comes to me the studies right? So, because I say to them, if you decide to go on, first of all, I want you to make an informed decision. You should see the studies first. You should read them. And you are going to refer to these every time one of your friends, your relatives, your healthcare providers, your doctors, anybody comes at you and said, these are dangerous, don't take them. Here's the studies. They're new. They're not the ancient Women's Health Initiative study from 2002. I mean, I was around doing bioidentical hormones before then, and I was around when all the women came off their hormones, and it was a disaster. It was a total disaster. And, you know, by and large, you know, somebody hijacked that study, came to conclusions before the scientists could, you know, present it properly, and it became like viral misinformation. And no amount of studies after that changed it. And even the principal investigator came out with a paper in 2017 that's, you know, 15 years after the study, saying it was debunked. This is not what it doesn't cause that. And nobody listened. Now people are listening. Now people are starting to listen because they have newer studies on the bioidentical hormones, which means the exact same chemical structure as your body. And we know when to give it, we know how to give it, we know that there are differences.
Yeah. Yeah. I mean, it's probably 30-40% of the patients I put on hormone replacement therapy are all like, but is it going to give me cancer? And it's like,
No.
that's not what the research is showing. But we do know it really is best to start hormone replacement therapy somewhere in the perimenopausal, early menopause years. You don't want them to be deprived for 20 years. I'm like, oh, okay, let's do this now. Because you may hit more bumps of the road because it's just kind of a shock to the system.
It is. Perimenopause is the hardest time in a woman's life. And women don't realize, everybody thinks you lose bone only in menopause. No, if you have anovulatory cycles, meaning you do not ovulate and do not make progesterone, your bones are weaker. When you have progesterone also helps bone grow, and it helps stabilize bone. It stops the bone breakdown. So you need to start that early. You need to start that in perimenopause. And there's no clear definition. I mean, it's a clear definition with menopause. Okay, 1 year without a period, check. But perimenopause, it fluctuates so much. Women just don't know what's happening to them. All they know is something is different. When I was in perimenopause, my best friend said, your personality has changed. And I was like, oh. And that hit me because I was under tremendous stress. And I just thought it was stress. And the minute I took progesterone, oh my God, I was a different person. I could cope. I could sleep. I was calm. I didn't snap at people, or I didn't hold, I always chose the right words with my staff, but there was an underlying irritation tone. You could tell, right? And, I lost some friends, and I got people like, I'd walk into a room in the office and people would part like the Red Sea. They'd be like, oh no, what kind of mood is she in? Right. And I'm thinking, I'm always trying to be nice. I'm polite. But that somebody said to me, it's your tone. There's some underlying tension there. Right.
Yeah. And perimenopause is just really this, especially now in today's world, it's very chaotic because it's not oh, well, you're going to have normal cycles, and then you're going to have perimenopause for a year, and then you're going to make the full transition, because of the lack of sleep, the overexertion, the amount of stress that people are dealing with, the amount of chemicals. I mean, you'll get people who will be in perimenopause for what seems like 5 to 10 years, and it's because of all of these exposures and things that's challenging their system. I don't know, the research shows, but I would assume perimenopause was never supposed to be a 10-year thing. But yet there's more and more people who are like, my cycles have just been off. Because we even know that in teenagers and athletes, right? Those teenagers who play very aggressive sports where they're running a lot, even that throws off their cycle.
Oh, yeah.
And so you basically have people heading into perimenopause earlier, and one of the things, as we're talking about brain health, is there's been research that shows the earlier someone goes into menopause, the greater the likelihood they end up with dementia or Alzheimer's.
Yeah.
Right. And so probably
Yes.
something that can be offset with hormone replacement therapy. And we'll come back to some of that. But there was something you said earlier that I want to get to. And that was the amount of people that you see. And I see many of the same people who come in, they're on hormones. Maybe they're in menopause and they're on hormone replacement therapy. Maybe they're in the perimenopause state and they don't even get their labs done. Or if they do, they get their labs done once. And then from there, the provider basically just manages on symptoms.
Yeah.
So I want you to kind of talk through that, because this is something I routinely see that creates a ton of issues for patients. And then they have to go through a period of not liking us as we try to get them back in a bed.
Yeah. Yeah. Well, a lot of women come in with fatigue. There are more than 20 reasons for being tired. Is that menopause? It may not be, and it could be cortisol, or it could be lack of testosterone, or it could be lack of DHEA, or it could be you have a viral infection, or you have, Epstein-Barr or whatever. So I had a woman, I'll tell you a story. We were trying to, I'm managing her, and when I try to have women be able to titrate, meaning, adjust the doses based on symptoms until I get to measure, right? Because I can start 10 women on the same dose and they're all going to react differently, even regardless of what their levels are, because their absorption is going to be different. The way they respond is going to be different. So in the first 2 months, because it takes 2 months for hormones to reach their peak effect, I have them adjust the dose by their symptoms. And then this one woman she was very dramatic. She was like, my breasts, they're so tender, they're awful, whatever. So I actually, because she was super, super sensitive, I actually had her test her urine using, some of those pregnancy apps will tell you, are you ovulating? Do you make progesterone? Or what's your estrogen? We both determined that breast tenderness had absolutely nothing to do with her hormones. She was so off with the symptoms. And the same thing with, when you're bleeding is irregular, you might start to bleed. But I've had women with cervical polyps. Polyps don't respond to hormones. Hormones are not going to stop the bleeding from a polyp, and they're not going to start the bleeding from a polyp. They're their own thing, and you have to know when to look. So I always measure, and it's because you could make the wrong call. And I have some women coming into me with, all those symptoms of perimenopause, and their hormones are great. They're stressed out, except maybe their cortisol is off, or they're not eating properly, or they're exposed to different toxins that are not very good for your brain or your overall health at all. But there's too many reasons to have those symptoms, and unless you measured, you can't know.
Correct. There are too many reasons, because one of my frustrations, and this is both traditional medicine and even functional medicine, is there's a lot of overcompensation for hormone replacement where people aren't measuring as much, or they're pushing people into these insanely high levels. I'm like, look, even during their menstrual cycles, they would have never produced that much estrogen.
Right.
And they're shooting them sky high. And one of the big things I see, especially when people are doing oral estrogen, which we can talk about the different types of replacements that can be done, is oral estrogen tends to increase thyroid binding globulin. So I've had people come in and they basically get hypothyroid from their oral estrogen that they were prescribed. And I'm just like, okay, we've now got to switch you to a different type. We've got to get you on the dose. So let's talk about that. What are the different ways, right? I'm going to say progesterone's pretty easy, right? There's a good pill, works well for most people. There is a topical, but for estrogen, what are the different things? Because there's a lot of different confusion out there on it.
Well, I would never give oral estrogen, because oral estrogen can cause clots. It goes first pass through the liver. You swallow it and it's going to go through your liver first, and the liver is going to make clotting factors, and it definitely increases the risk of clots. And this is one of the reasons they stopped the Women's Health Initiative early, because they had an increased risk of heart attack and stroke. Now, if you give estrogen through the skin, whether it's a cream, it's a gel, it's a patch, you don't get the clots. The risk of clots is negligible because it's absorbed right into the capillaries and taken to your system. And they did show that it's safer, that there's no increased risk of cardiovascular disease with what they call transdermal, through the skin estrogen. So I tend to use the patch because it's covered by insurance. You can cut it to adjust the dose. Sometimes people are sensitive to the glues, or they might get itchy, or the patch doesn't stick well. I might use the gels. And in others that are super sensitive, I tease her because we have a very good relationship. I call her the princess and the pea. If I change the dose, even a milliliter, she reacts, right? And so we keep her at a dose that makes her comfortable. And they don't make a patch small enough, and she can't even use a sliver. So then I'll have a cream compounded, and this way it's gentler. And that's the only time I do that. But why give a woman? I had a woman who wanted to come to me, and she was on Trieste. Trieste is estrone, which you don't want. Estrone is made in your fat and adrenal glands during menopause. It's very inflammatory. And estrone has shown to increase the risk of breast cancer, and also increase, if you develop breast cancer, metastases. And estradiol, the really nice estrogen that gives you back your brain, your bones, your lipids, helps your heart, that will displace the estrone, so that you're signaling with the good stuff, not the bad stuff, right? And you're giving the right signals that your body wants. And the interesting thing is, the women that had breast cancer in my practice were not on hormones, right? Women not on hormones get breast cancer, but women on hormones can, but maybe for other reasons. It has nothing to do with the estrogen. Progestins, you asked about intrauterine devices, and a lot of them are progestins, synthetic progesterone. That's been linked to breast cancer. Natural bioidentical hormones, and there are papers on this, are found to be safer. Progestins increase the risk of breast cancer, yet no one would bat an eye to give a young woman, and even an older woman, and even a menopausal woman, the pill, which is synthetic. And A, it causes clots, and B, it increases the risk of cancer, as well as gallbladder disorders and other things. So we're nobody's hesitant about taking the pill, but this is what we're finding. No one would admit it for a long time.
Yeah, and I think there's some key takeaways. One is it's not estrogen, it's the route of administration matters. And because one of the things people ask me is, right, they'll get their estrogen patch, which is typically what I'm using as well, right? Insurance usually covers it. And even if they don't, it's actually pretty cheap through GoodRx or other things.
Yeah.
Or else if they're sensitive, because I do have some people sensitive to the adhesives, that you do the cream, and they're like, but it says it could cause this. It's remember, all side effects they put on there are based upon the FDA approval off the pill of estrogen, not versus the current route of administration you are getting. And we see the same thing in testosterone or anything else. Mm-hmm. And so it's based upon that initial approval. Because I do have people who start freaking out. They're like, oh no, it says this, and you told me it's not. I'm like, different route of administration. It's not that big of an issue. Now, one of the things I do want to ask, because people do wonder this, is there's a lot of people using the term bioidentical. So for example, the patch. Is the patch considered bioidentical?
Yes. Estradiol, you have to see what it says. Estradiol is bioidentical. It's the exact same estrogen that your body makes. That's why the bio, it's your biology. It's identical to your own biology. And if the word progesterone has anything before it or after it, except for the name micronized, it's progestin, it's synthetic. And that's what confuses a lot of people, because the press is going to call progestins or progestogens, which are synthetics, they call it progesterone, and it's not. There's only one progesterone. It's progesterone, plain and simple, progesterone, right? Not medroxyprogesterone or norethindrone or whatever. It's just plain progesterone. And, for a long time, they were not able to make that. And once they were able to make micronized progesterone to take orally, and I prefer the oral route. Not everybody can take the oral route because it's calming. It allows you to sleep, and it has very, very calming effects on the brain. And we've used not me personally, because I don't take care of these people, but when your brain gets injured, your brain is going to make more progesterone to protect your neurons. And progesterone has been used in stroke and people with traumatic brain injuries because it protects the neurons. It lets them, it gives pain relief. It decreases the amount of damage. And, it's been used for some, I don't have a lot of studies on this, with MS. It remyelinates and it protects nerves against damage. So progesterone is really a quite important hormone. So you can't have one without the other, right?
Correct.
The knee bone is connected to the thigh bone, is connected to your hip bone, is connected. You can't, you can't walk with like half a foot and no knee, and you need it all. You need it all to work together. And it's, those estrogen, progesterone, testosterone, DHEA, cortisol, they all have a very big role to play in your brain health and in your overall health.
Yep. Yeah. So two takeaways is: one, estradiol patches are bioidentical. Two, oral progesterone micronized is also bioidentical. Now, sometimes people do have to do compounded on the progesterone because they only go down to 100 milligrams, and some people actually have to do a lower dose. But I did want to clarify that, because for some reason in the natural health space, specifically on the patient side, as they're looking for oh, well, is it coming from the compounding pharmacy? It's like, well, look, it's okay. Like, these actually can be bioidentical and not come from a compounding pharmacy.
Yeah.
They don't necessarily get a monopoly on that. And then as far as the progesterone, even though I do treat a ton of brain injuries, I haven't necessarily used it on that side, just because the results really are pretty mixed in the research. There's not yet a solid agreement, and there's other things that do work really well, more predictably. But let's talk about now testosterone, the most abundant hormone in everyone.
Yeah.
So,
DHEA is actually more, but testosterone too. But testosterone is a very potent neuromodulator. And, men who have low testosterone have much more anxiety and depression. And women, testosterone decreases. There's maybe 20% of women as they head into menopause where testosterone actually increases. The lady with the beard and the mustache, right? Yep. I'm Mediterranean in origin. So, my whole family has that. But in most women, it goes down. And when it goes down, it increases anxiety. And women have more anxiety and depression than men. And we think it's due to all these hormone fluctuations and the fact that they have less testosterone. And the androgens, testosterone and DHEA, are very calming. They are anxiolytic. They decrease anxiety. They lift moods. I say to my ladies, because they'll ask about testosterone, and sometimes I don't want to start people on everything all at once because, your liver has to handle all of this, and you may not need it. So I say to women, if you are more sensitive to things that didn't bother you before bother you now, if you're less self-confidence, less self-esteem, you have no libido, then you'll benefit from testosterone. And again, you have to measure, because I had a woman whose hormones were perfect, and she said, Dr. Maita, I came to you because I don't have libido, and I still don't have a libido. I said, well, your hormones are perfect. What about women? If you have, you're tired, you're ill, you have pain, you're stressed out, or you have any anger or resentment, the first thing to go is like a libido. I never forgot the slide where they showed a slide of men, testosterone on, off, right? Women, it's the airplane cockpit. There's so many things that go into that. So when we had a deep dive into that, she said, yeah, my husband travels a lot, and when he comes home, he's too tired and he doesn't pay attention to me. And I do resent that. And they worked on it, and you know what? Her libido came back. And years later, sad to say, her husband ended up dying. She met somebody new, and wow, great libido. There was never an issue, and it wasn't testosterone, but it can help your libido for sure, and it helps you with self-confidence, self-esteem, and decreasing anxiety and depression in men and in women.
Correct. Yeah, testosterone's great, and like you said, the psychological factors, the mental health, the mindset plays a massive role in libido. And sometimes people are like, oh, well, I'm not. It's like, no, look, what's happening with your stress, what's happening with your sleep, right? What's happening with all that can definitely play a big role. And as we've talked about, right, we've talked about testosterone, estrogen, progesterone, and really the role that these play in health, and trying to get things to an appropriate level, because these are all so critical for really almost every aspect of health, from immune system to bone health to cardiovascular to neurological. There's research on testosterone. The higher the levels, actually, the less likely to end up with prostate cancer. I mean, like there's a ton of stuff out there on it. And there's something you've hit on multiple times that, I think we wouldn't do this justice if we didn't talk about it, was testing.
Yeah.
Right?
Definitely.
How do people go about getting some of these tested? Because as we've talked about, we both see patients on a regular basis who, when they come to us, we're the only people who are actually repeating tests or even doing the initial test to begin with.
Yeah. Well, I test 3 ways. I say to people, if I were to do your financial plan, I'd have to look at your bank account, your savings, and your income and expenses to do a good job, right? So if I just looked at your blood, and that's like your bank account, well, there's the most studies on blood. I say, oh, you have enough, right? But we don't know where it's going in your body and what your body's doing it. I do sometimes match blood with saliva, because I do have some people that they're low in blood but they're high in saliva, or they're high in blood and they're low in saliva, or they're equal. It's measuring something completely different. It's measuring saliva is free hormone, and blood is free hormone, which is the only thing that gets into the cells and works, bound to protein. So that people who are on oral estrogens or the birth control pill, they make more of something called sex hormone binding globulin. And that is going to hold on to their estrogen. And it's also going to lower thyroid, so that whatever the level is, it may not be as effective because the protein is holding it. And I say it's like, counting the people in the train station and the people in the train with the doors closed, like the estrogen bound to sex hormone binding globulin, they're not free to go to work. So you take estrogen orally, you're increasing the sex hormone binding globulin, and you're decreasing the free hormone that's actually going to work. so that I measure blood and I measure blood and saliva. And then when the levels are adequate, then I will measure urine, because the Dutch test, because, I see too many people measuring it, and there's a time to measure it when you're not on hormones. But if the estrogen's too low, it's not going to be very accurate. But I use that to look at how your body breaks down the estrogen. And your liver is like a recycling plant. It's going to break it down, either clean recyclables like benign 2-hydroxyestrogen, or something's a little 16-hydroxy, which is semi-toxic, or 4-hydroxy, which is quite toxic and known to damage DNA. So knowing that, wouldn't you want to know that? Because if you make the toxic form, you can change that into less toxic form by supplements and diet. And I have to say that what I've been seeing in practice correlates with the studies. Women who make 2-hydroxyestrogen, they almost never had a history of breast cancer or a family history of breast cancer. The women who make the 4-hydroxyestrogen had a family history of breast cancer or a history of breast cancer. So let's fix that. And also, just like you wouldn't throw your garbage out on the curb without bagging it or putting it in a container, your body needs to methylate it. That's like putting it in a bag so your body can dispose of it. So that urine test is going to tell me that. And it's also going to tell us, is your androgen breakdown more going to give you more masculinizing effect or less? Or is your progesterone going to make you more tired or less tired? Are you making free cortisol? I mean, there's so much information in that test that I feel like it's almost, it's not a good thing not to test that, because you want to know.
Yeah, and I think, you did a good job, and I just want to clarify for people as distinguishing almost when a test would be performed and kind of what for. I've had people who come in, they've seen other providers, they've had the Dutch, and they're actually trying to prescribe them based off the Dutch. And I'm like, I don't know that I'd use the Dutch to actually prescribe someone, right? So so it's like blood's probably the best for prescribing, even though salivary is there kind of as an extra. And with blood, always tell people, if you can, get free levels of, LC-MS is what it'll say on the labs. And then you're coming around on the back end and saying, okay, how well do you break it down? Because as you said, right, our liver has to break these hormones down and have the appropriate balance of them, and then come in with the right dietary support if needed, right? Calcium D-glucarate and all, DIM and other things like that can help with the different pathways in the liver with getting these to more of an appropriate spot. Now,
and it's the same with men with prostate cancer. They make more of the 4-hydroxy. So I do it on men too, because your men have to have some estrogen for memory, and if they're if they are taking that estrogen and making it into 4-hydroxyestrogen, they have an increased risk of prostate cancer. So I do it on the men too. This is not just about women, and you have to be careful how you give the hormones to men as well. I used to see men who came in on the injectables, and they would come in and they'd be in a rage when it's high, and then they'd come a week later like, oh God, I'm like so depressed. They'd have these wild mood swings. They had increased red blood cell counts, which, the more red blood cells you have, it gets kind of crowded in your arteries, and you have an increased risk of clots. And they would have elevated liver enzyme because it's not bioidentical. So I tend to like giving testosterone through the skin as well. And I never see high red blood cell counts or liver enzymes elevated. And it's a steady dose, so you don't see those mood swings. It makes such a difference.
Yep. Yeah, I mean, having that balance is important, because if there's one hormone for both sexes that's fairly consistent, it is testosterone, you know? And so having a good, consistent way, whether it's more frequent injections versus topical, right? But not having it to spread out, because that's just much more of a roller coaster. This has been really good. What's one takeaway you want the listeners to have from our conversation on this, that if that's all they remember, you're like, that's going to serve them well.
Well, everything affects your hormones. What you eat, what you drink, how much you exercise, the stress you're under, the toxins you're exposed to, and even what you think can affect your hormones. So you have to look at the whole picture. And when you check off all the boxes and you do it right, sometimes the hormones just come back into balance on their own. But if you're going to be on hormones, make sure you measure and you make sure you take it the right timing, the right dose, in the right way.
Correct. Yep. Because as you do it, as we talked about, right, you reduce potential risk of side effects, you get the most benefits out of it.
Yeah.
And then, as you said, the body, nothing in the body exists in isolation. And so you just listed a ton of things that we know impact hormone levels. And I'll often tell people, they're like, well, my testosterone's really low. I was like, well, you kind of got two options, right? We can either replace it, or two, we start working through the system, because there's not just one thing sometimes there's one thing you fix it and their testosterone shoots back up. Other times it's like, honestly, there's a lot of stuff that normally weighs on the system, and we have to work through those things to reduce the outside stress that's impacting our body's ability to produce. So, Dr. Maita, it was great having you here and sharing your wisdom with my audience.
Well, I love to get the word out because I hate seeing people suffer, and people are suffering needlessly. And there's a lot of myths that we have to break. And thank you so much for inviting me.
Yep, you're welcome. And then just, one last thing is, if people wanted to learn more about you and the work you do, where would they do that?
Okay. My New Jersey has funny laws. My medical practice is vibranceforlife.com, and my courses and coaching practice is the feelgoodagain.institute.com. Plus, Lorraine Maita MD is on Facebook, and at Lorraine Maita is on Instagram. I'm also on YouTube, and you can just Google my name and you'll find me. I've been around for a long time. You'll find me.
Awesome. Sounds good. Thank you so much.
Thank you.
If you have found the material valuable, please subscribe to my YouTube channel, Dr. Spencer Zimmerman, and leave us a 5-star review on Apple Podcasts or where you normally listen to podcasts from. If you would like to work with me, visit peakbrainandbody.com to learn more. You can find me on YouTube, Instagram, Facebook, or TikTok, all with the handle Dr. Spencer Zimmerman. I'm also on X with the handle Dr. S. Zimmerman 5. This podcast is for general information purposes only and does not constitute the practice of medicine, nursing, or other healthcare professional services, including the giving of medical advice. No doctor-patient relationship is formed. The use of this information and the materials are to be used at the user's own risk. The content on this podcast is not meant to be a substitution for medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice for any medical condition that they have, and should seek the assistance of their healthcare professionals for any such conditions.